So back to you, Ricardo. I'll tell you a story. I had a patient coming to me, and really the patient is totally eligible for a embolization. And I suggested that I refer to embolization. He said, no, I want a checkpoint inhibitor. I want immunotherapy. And what I'm trying to relay here is, have you thought of any sequential use of the therapies between the local and the systemic? And which one, in your perception, or you're kind of seeing patients more engaged in regard, checkpoint inhibitors or TKIs? Like, your thoughts?
Yes, I mean, clearly the combination between local regional therapies and particularly TAs with TKIs truly failed to provide a meaningful clinical benefit. So there is a focus today on the potential synergistic effect between a local therapy, and particularly chemoembolization, with checkpoint inhibitors. Why is that? Well, we know that all local regional therapies induce an immune response. But usually this is not really able to translate into a meaningful effect. I've never seen, let's say, an abscopal effect. I've never seen regression in a tumor that was not directly targeted with ablation or chemoembolization. However, the tumor disruption, the increased antigen exposure, the enhanced T-cell activation, there is work that suggests that this immune effect induced by chemoembolization could then be amplified by checkpoint inhibitors, and there are several studies at this point of time investigating, which combination and which sequence is best.
We'll hold on that thought, and we have two things that we still would like to spend a lot of time with you on. But before we go there, I'm going to ask actually, and I'll start with Mike, TKI followed by a checkpoint inhibitors, or checkpoint inhibitor followed by TKI. Your thoughts? What's the sequence you think?
I guess we have to get to this question at some point. Right? Thanks for making me the first one. The simple answer is, I think our thinking around this is probably continuing to evolve. I, like most people, would have previously said, well, it depends on how they did on their original therapy. But what we're seeing is it doesn't actually translate, that regardless of how long you were on or how you tolerated your first-line TKI, you can still do well with the second-line TKI. For some patients, they do come with an interest in immunotherapy, and so we certainly want to defer to them. In other people, there's a sense that changing mechanism is important. Changing the toxicity risks might be more appropriate for that person, but I'm not sure I can tell you that I have a strong way of navigating this question.
Well, to be fair, probably none of us know. But anyway, to kind of re-summarize and hash what you just heard, the checkpoint inhibitors, no question, they definitely have a substantial value in regard to treatment in HCC. If anything, two of them already are conditionally approved by the FDA, being the pembrolizumab and nivolumab, with the understanding that probably it was more the duration of response rather than anything else, because the response rate remained limited to the 15% per se. However, clearly, and I think we all kind of agreed that we were definitely, number one, surprised. Number two is we're trying to understand and explain the negative pembrolizumab versus placebo phase 3 data, and the upcoming, we're going to see the data. None of us know the data yet of the nivo versus sorafenib. However, nonetheless, despite what we just heard about potential kind of explanation points why the trials could have been negative based on some statistical design issues, at the end of the day, it didn't work. And if anything, it really brings in a little bit of better understanding in our mind in regard to what's criticality about the anti-PD-1, anti-PD-L1, and what is the involvement of the anti-CTLA-4, and maybe the combination of the two is going to be the critical component. anyway, day after day, I'm seeing more that HCC is not like really an anti-PD-1, anti-PD-L1 disease. It's more an anti-CTLA-4 disease. And I think Tim already suggested that in the discussion as well. Nonetheless, as also Catherine mentioned, the combinations we're really very intrigued by. And we have, of course, the atezolizumab that we kind of were very intrigued by, and we're waiting for more data from the EMBRAVE. We have the atezolizumab. In addition to that, we have the pembrolizumab, and I would say there will be more to come. So between the durvalumab, tremelimumab, as well as the different combination of the TKIs plus checkpoint inhibitors, I think we have plenty to wait for to see.